A very good day to everyone. A very warm welcome to the Medical Saga YouTube channels. My name is Dr. Tan. Today we are going to learn about dengue fever. Personally, I believe that dengue fever should be a topic that is very close to all of our hearts. This is because dengue fever is actually an endemic disease in the Southeast Asia. Not only that, dengue fever is also a very unique and fascinating disease because of the clinical manifestations of its own. And of most importance, dengue fever is a highly treatable condition. Therefore, I sincerely hope that I can have your attention in the next 20 minutes so that we can run through the importance, the pearls and perils of dengue fever. For those who have not been taught on dengue fever, I think this lecture will serve as a very good starting point, before you read more about dengue fever. And for those who have already been treating dengue fever, I think you can definitely have some takeaways from these videos because we are going to discuss on some of the practical aspects of dengue fever. So without further ado, let us first take a look at the outline of my presentation today. As we understand, dengue fever is actually very broad topics. I think definitely it's not possible for me to go through all the aspects of care and dengue fever. But nonetheless, in these video lectures, we'll be focusing on the dengue fever pathophysiologies and clinical manifestations. Besides that, we are going to discuss about the dengue diagnostic test. And last but not least, we will be also discuss briefly on the dengue notifications, the principles of general management, and some key takeaways, during the management of dengue fever. Let's get the ball rolling by first taking a look at our World Health Organization's health emergency appeal dated 2024. So from this excerpt, it's evident that dengue fever is a very rampant disease, not only limited to tropical countries, but as well as countries with a subtropical climates. As you can see here, dengue has become a growing public threat. Even though it's just a small bite, it can cause a big threat to humanity. So based on this document, there was approximately 4 billion people in 130 countries identified at risk for Aedes-borne infections. And since the beginning of 2023, the world has been facing an upsurge of dengue cases and deaths reported in the endemic areas. Not only that, it's also noted that dengue infections have been since then been spreading to areas that was previously free of dengue. I hope this would actually, impart on you that, dengue infections is here to stay, and it will only wax and wane, depends on the climatic changes. Hence, it's very important for us, to understand this disease. After appreciating the global burdens of the dengue virus infections, I think now it's high time for all of us to learn about dengue fever in greater details. So I would like to begin the lecture today by first sharing with you the pathophysiologies of dengue's infections. Just like any other infections, we always need to familiarize ourselves with the agents. In this case, dengue infections is actually caused by dengue viruses, and also what would be the vectors. So as I have highlighted in this slide, dengue is actually a mosquito-borne arboviral infections. So the vector would be the mosquitoes. And normally it's transmitted through the bite of an infected female Aedes mosquitoes, which can be the Aedes aegypti species or the Aedes albopictus species. And this virus, it belongs to the genus of Flavivirus and family Flaviviridae. And the dengue virus itself is actually a single-strand RNA virus. And dengue virus could be further subdivided based on their serotypes into dengue virus 1, dengue virus 2, dengue virus 3, and dengue virus 4. So another clinical pulse that I would like to drive home today is that, especially on why is it important to know about dengue virus, what families or what genus it belongs to. So because under the flavivirus, dengue virus is just one of it. And besides that, we have vaccinal virus, yellow fever virus, and also Zika virus, which falls under the families of flavivirus. And this flavivirus is unique because it has the hallmarks features or the hallmarks ability to secrete the NS1 antigens, also known as non-structural protein 1. And this glycoproteins is unique because it will be secreted by this flavivirus, and hence during the interpretations of the NS1 antigens, we also need to keep it at the back of our mind. This could be positive, not only due to dengue virus as well as the others flaviviruses, but nonetheless, in Malaysia, the most endemic disease we're talking about is still dengue virus because we rarely encounter the other viruses. But if there is a suspicious or there is a risk factors or there is a clinical manifestations that make you think that it can be due to the other flaviviruses who has NS1 antigen positive, I think that we should always escalate the matter by discussing it with our infectious disease team as well as with the pathologist, and to look for other tests that are more specific in order to identify the actual viruses. But nonetheless, in this lecture, as we are concerned that NS1 antigen positive, will be referring to dengue virus infections. Next, we'll pivot to another very important topic, which is about the clinical manifestations of dengue fever. So even though the name is dengue fever, but I would like to urge you to think about it that dengue infections, the manifestations is actually has a very broad spectrum. It can have a subset of patients who are asymptomatic or who have very mild symptoms that are self-limiting, or they can belong to the other end of spectrums, which is patients who are symptomatic, with warning signs, with multi-organ involvement, requiring admissions or even ICU care. So keeping that in mind, it's not wrong to say that dengue infection true prevalence is always elusive, because we are only capturing those who are symptomatic, and those who seek medical care. But nonetheless, I think for the purpose of learning dengue fevers, in these lectures, we will focus on the typical symptoms of dengue fever. So I hope you can recognize that dengue fever is always a febrile illness. They can have, most of the time they come with acute febrile illness. So besides that, they would also complain of in general, I'm saying in general, I wouldn't say that all patients will tick all these little boxes, but in general, they will present with fever, headache, retroorbital pain, arthralgia, myalgia, rashes, vomiting, diarrhea, abdominal pains, or even with hemorrhagic presentations if the platelets is reduced to a significant levels. Just like any other tropical infections, so during our cooking, we will always actively elicit risk factors in order to assist us in formulating our differential diagnosis. I think as for dengue infection per se, we will always ask, is the patient from dengue-prone areas? Is there any reason fogging activities in the place that they are residing in or even in their workplace? And also, is there any recent jungle trekkings? How is their working environments and how is their residence environment like? And also, not to forget, ask about traveling history, because they could have acquired infections from the last place that they traveled to. So besides that, also urge you to understand that in clinical practice, there would always be other presentations. For example, patients with dengue infection, they can come in with decompensated organ failure or major organ involvement. Like for instance, they may come in with acute respiratory distress due to decompensated CCF, due to myocarditis, or decom CCF due to the active dengue virus infections, or maybe because they missed a HD because unwell, so they came with fluid overload, or some of them they came in with status epilepticus because of dengue encephalitis, or other cerebral symptoms due to dengue associated cerebralitis, or DKA due to missed medications, or GI bleeding because of they did not recognize that they got dengue infections, their platelet levels was already reduced, and then due to the concomitant medications that can potentiate bleeding, they may actually develop gastrointestinal bleedings. So henceforth, I want you to keep an open mind that any patient that came in with febrile illnesses or with recent febrile infections, we just need to keep dengue fever as one of the differential diagnosis. But of course, you can always rule it out through your further history taking, your investigation, as well as point of care test if needed. To illustrate my points on the fact that dengue fever could have a diverse presentations depends on the clinical stages. I have actually selected a few articles from the online literatures or from the online biomedical libraries. So to illustrate to you, dengue fever can range from asymptomatic or to very mild febrile illness to fatal dengue fever, multi-organ failure, and hemorrhage. Or they can also have a neurological manifestations, with respiratory or cardiac manifestations. And sometimes dengue fever infection could even coincide with other bacterial infections. So keeping that in mind, I think as practicing doctors in the countries where dengue infections endemics, we must always maintain low suspicions of dengue fever, when we are treating our patient, especially when there's a risk factors and the clinical symptoms are compatible with dengue infections. Moving on, we are going to discuss about the clinical cause of dengue infections or dengue fever. I would like to first draw your attention to this diagram, which is adopted from our Malaysian dengue infections in adults CPG dated 2015. Broadly, dengue infections could be divided into three phases: febrile phase, critical phase or defervescence phase, and finally the recovery phase. And the day of illness as stated here are just arbitrary, because febrile phase can last up to 2 to 5 days. In very rare case, sometimes it can be up to a week. So after the fever has subsided, they will enter the critical phase, which normally lasts between 24 to 48 hours. But having said that, it depends on the severity of the dengue infections. If the patient is having a very severe dengue illness with multi-organ involvement, the critical phase can last more than 48 hours. And finally, the patients will enter recovery phase. And there are different sets of clinical challenges during each of these clinical phase, and I will talk about this in depth in the upcoming slides. And also in terms of laboratory results, what would be evidence would always be the platelet counts during each of these phases. Normally the platelet count will drop dramatically or will drop substantially when they're entering critical phase. So that is the time that we need to actively watch out for dengue complications. What we are talking about is organ decompensations. We are talking about also about plasma leakage. So the plasma leakage, in terms of laboratory results, they will manifest with a rise in the hematocrit. But of course, they could also manifest with a hemorrhagic, complications. But the one I think we'll talk about it later. But nonetheless, I think I want you to keep in mind that platelet counts is a very good predictor of the severity of dengue infection. It also help you to predict the trend. The trend of platelet will help you to predict as well which phase are they in. And so besides that, you should also look into the total white cells as well, because they will have leukopenia as well, which should correlate with the platelet counts changes. Last but not least, I hope you can recognize that during the febrile phase, they are very viremic. So they will be circulating NS1 antigens. So therefore, we always say that the first 5 days of NS1 antigen will be expected to be positive due to the viremia. And then after 5 days of illnesses, normally the NS1s will subside and disappear. So what will arise after the day 5 illness will be our IgM and IgG, which is your dengue's serology test will be positive. Overall, I hope you can appreciate that dengue fever or dengue infection, it is a dynamic disease with 3 distinctive clinical phases, namely febrile phase, critical phase, and recovery phase. And to distinguish which phase is the patient in will requires not just all these parameters, but as well as on the combinations of clinical symptoms, the patient well-being, their appetites, their vital signs, the laboratory changes, as well as a combinations of other important skills when you are treating inpatients, patients who are at high risk of deteriorations or who are already in a decompensated state, would be the utilizations of ultrasound in this aspect of care. This slide is just to recapitulate the main points that I have highlighted earlier. So during febrile phase, the clinical manifestations would be that patients normally will have fever lasting between 2 to 7 days. It will be a sudden onset high-grade fever associated with arthralgia, myalgia, headaches. They may also have mild hemorrhagic manifestations if the platelets has already dropped significantly, and also they may have tendons, right hypochondria because of hepatitis, and also progressive leukopenia and thrombocytopenia. And this in general coincide with the viremic phase, and NS1 antigen will be detected during this febrile phase. So the clinical challenges during this febrile phase would be dehydrations, because clinically they are generally unwell, they have reduced appetites, and also they are at risk of increased insensible fluid loss. So depends on the hydration status of the patient and the well-being of the patients. Sometimes they need to be admitted, for hydrations. And also the fever should also be paid attention, because untreated high-grade fever can precipitate neurological disturbance or trigger febrile seizures. Normally if they have high-grade fevers, we will generally ask them to actively do tepid sponging. If the liver function test is intact, they're allowed to take paracetamol. But if fever is too relentless, sometimes we can admit and observe, and provide a symptomatic care to this group of patients. So next will be the critical phase. In general, it lasts about 24 to 48 hours. It starts around the time of defervescence. What you see is that the leukopenia and thrombocytopenia will drop further, sometimes even at a faster rate than what was observed during febrile phase. At this time, we also be actively looking out for other complications, especially like plasma leakage. Like for examples, during assessment, we will actively examine the patients for the third place of fluid loss. Like in terms of laboratory result, will be rise in hematocrit. In terms of clinical findings, we will also look at the vital signs. Is there any derangement of vital signs to suggest so? And is there any reduced air entries in the lung spaces? And then also, is there any signs of ascites? But I think ascites will be a very late sign, because there need to be a very substantial amounts of ascitic fluid in order to allow the shifting down to be positive. So clinically, if you suspect that there is plasma leakage, we always apply the ultrasound to look for free fluid in the abdomen. We can actually detect the clinical significance plasma leakage earlier, as opposed to your shifting downness. Yep. So what will be the clinical challenges during this critical phase? So it will be hypovolemic shocks or hemorrhagic shocks, cardiogenic shocks, depends on the organs involved, lactic acidosis, DIVC in a very severe or a very end of the spectrum, where the patients have a very critically low platelets, as well as a consumptive coagulopathy. And also, not uncommonly, in a subset of patients, because of the cytokine storms or the immune dysregulations, they may have an overactive immune system that lead to hemophagocytic lymphohistiocytosis. But most of the time, they will have a persistent temperature spike still, with very low platelet counts, or the very severe thrombocytopenia, with as well as hyperferritinemia and hepatitis. So last but not least, if they have passed through the first two phases, they will eventually enter recovery phase. So during this time, there will be gradual reabsorptions of the extravascular compartment fluid. The well-being will improve. The counts definitely will be improving. So, they will show uptrends in the total white cells, the platelet counts, and also they will improve in urine outputs. Some patients we will observe this quite interesting rash. We call it Isles of White in the Sea of Red, and sometimes they may complain of pruritus because of the rashes. So But nonetheless, I think during recovery phase, they would also pose a very small, a small subset of patients because of the previous overzealous fluids resuscitations. There is a risk of, fluid overload as well during recovery phase because as they reabsorb the third space fluid, sometimes they may have congested pulmonaries, parenchymas that will lead to respiratory decompensations. This is something that we need to watch out during each of these distinctive clinical phases. Next, I would like to bring your attention to this diagram, which is very important and it is adapted from the WHO. So in short, dengue fever, we will classify either based on the presence or absence of warning signs. So it will be dengue fever with or without warning signs. So I would like to first begin by highlighting to you what are the dengue warning signs that we would be actively eliciting when we are seeing a dengue patients. So number one would be abdominal pain or tenderness. Number two would be persistent vomiting, defined as 3 times per day or more. Number three will be persistent diarrhea, defined as diarrhea episodes of 3 times or more per day, and also clinical fluid accumulations, mucosal bleed, lethargy, confusion, restlessness, tender liver, and laboratory changes will be, reflecting the rise of hematocrit, or also known as hemoconcentrations, with a concurrent rapid decrease in the platelet counts. If the patient has any of these warning signs, they would require inpatient care because they require strict observations and medical interventions during the hospitalizations, because this group of patients in general, if they have warning signs, they are at a higher risk of further clinical deterioration. So next, we're going to pay attention to the criteria for severe dengue. Broadly, severe dengue could be subdivided into, dengue with severe plasma leakage, dengue with severe hemorrhage, or dengue with severe organ impairments. But in practice, they can have a combinations of any of these three, criteria. But nonetheless, let's take a look at the criteria for each of the definitions. So severe plasma leakage will be defined as plasma leakage that is leading to shock or fluid accumulations with a respiratory distress. And the other criteria will be severe hemorrhage. So it will be defined as severe bleeding as evaluated by clinicians. And last but not least, severe organ impairments. So in this criteria, the patient would have either one of these, for example, like liver impairments with raised aspartate transaminase or alanine transaminase measured at thousands and above. CNS would be referring to impaired consciousness or hearts and other organs that decompensations. But overall, I would say that this is just classifications criteria for severe dengue, because in practice, most of the time the patient would have combinations of challenges. It may not be just limited to one. Even though they may first come in with severe plasma leakage, we will also need to be on high alert on the other additional organs impairments or the accruements of additional complications as the patient is actively deteriorating during the course of illness. To those who have a curious mind or who are inquisitive, who wanted to learn more, I believe up to this stage, I must have at least piqued your interest in wanting to know more about the dengue infection, especially on what is the pathomechanisms driving, the spectrums of symptoms, ranging from mild symptoms to multi-organ failure. Unfortunately, I think there's no straightforward answer to this. I think many of the pathogenesis studies on dengue infection is still ongoing, but at this moment I would say that dengue infections is caused by the complex interplay of immune responses, which could be due to the immune dysregulations, cytokine overproductions, dengue virus induced vasculopathy or coagulopathy, or antiplatelet autoantibodies, endothelial autoantibodies generations in response to the dengue virus infections, or it can be due to molecular mimicries, which again will lead to the productions of autoantibodies attacking the host own tissues or even organs. And last but not least, it can be due to the direct virotropic effects, caused by the dengue virus infections affecting the monocytes and the B cells. Overall, I think dengue's pathomechanisms is a complex, is an interplay of multiple immune responses listed here, but not exclusively limited to what I have listed here. I believe that with more ongoing studies, more mechanistic pathways will be revealed from time to time. In theory, it may be straightforward to diagnose dengue infection, but in practice, I would say that the dengue symptoms are quite non-specific, and it can mimic a list of other differential infections. So, for examples, if the patient presented with acute febrile illness, flu-like symptoms, arthralgia, myalgia, diarrhea, it's quite sensible for us to consider, could this be due to COVID infections or viral influenza or viral AGE? Or sometimes can this be due to chikungunya infections? But chikungunya, most of the time, they will have quite a prominent joint pains. But nonetheless, I think therefore it's very important for us to take a detailed histories to elicit the risk factors for each of these differential diagnoses, and also we'll pay attention to the local epidemiology. Or is there any outbreak in certain diseases? For example, has a patient been to a place where there is an outbreak of malaria? And also we always we'll look at the blood parameters if we couldn't distinguish what's etiology based on the symptoms. Yeah, and also nowadays I think what's very useful is that we have the widely available point of care test kits, like the test kit for COVID, for influenza, for dengue. So based on the results, we can make a clinical call or clinical judgment on what is the diagnosis, what are the infection patient facing. But nonetheless, I think it's still worthwhile for us to go through the differential diagnosis that we should be able to put forth or possess when we're seeing acute febrile illness with the symptoms that I had mentioned earlier. So first of all will be common viral infections. Common things are common like COVID, viral flu, influenza, or viral AGE, or chikungunya, or other tropical infections. This group will be very important because they definitely require inpatient care, and the treatments are quite specific. Like leptospirosis, you need antimicrobial treatments. For malaria, you need the anti-malaria treatments, and so on. So again, it depends on your clinical suspicions based on the things that I have mentioned here: history, risk factors, and also the other parameters that you will actively look into. But in general, if you are dealing with leptomalaria, typhoid fever, salmonella, or even sepsis, they are generally more ill. They will be ill, and also without treatments, they are actually destined to deteriorate further. Hence, very important for us to distinguish whether it is a viral infections. With most of the time they can be, they can recover on their own, cell-limiting viral infection I'm talking about, or can they be because of a sepsis? So it's very important, from your assessment in terms of history as well as physical examinations. And also other autoimmune hematological diseases, sometimes they may mimic dengue, like patient come with acute febrile illnesses with an undiagnosed ITP, or it can be acute leukemias. But again, I think the history will tell you, the count, the trends especially will tell you whether what disease it is. So therefore, I want all of you to keep open mind. If the symptoms or the trends of the blood parameters doesn't seem to reflect dengue infections, always keep an open mind. Can it be due to others type of infections which may need a different approach? After understanding what are the typical dengue symptoms, as well as what are the clinical phases of dengue infections, now we shall switch gear and we'll take a look at the types of dengue diagnostic tests that are available to us that will assist us in making the diagnosis of dengue infections. So I'm not going to talk about the others blood parameter tests. Today we'll just be focusing on the dengue diagnostic test kit. So broadly, it can be divided into 3 types of test kit. So we'll be looking at dengue combo test, or the also known as the rapid diagnostic test or the point of care test, as well as the dengue ELISA test. Just for information, ELISA is just one of the methods. How do they test for the dengue antigen and serology in the laboratories? Besides ELISA, there are other methods as well. So last but not least, we'll be talking about the molecular test, in which we'll be going to discuss about the dengue PCR and dengue serotype tests. So with regards to dengue combo test, it is widely used and it is widely available, not only in the hospital setting, but as well as in the clinic in the health clinics or in the GP setting. So it is actually an affordable test that will offer you a rapid results. So one of the plus points is that in the modern days dengue combo test, it offers the results of the NS1 antigen, IgM, as well IgG as well, which is actually clinically very useful. And most of the test kit has high sensitivity and specificity, but of course it will be affected by on the day of illness you are doing such tests. And also is the most prominent upside is that it can offer you rapid results on the spot within 15 minutes. So this would be a photo to illustrate to you how a common rapid diagnostic test kit for dengue fever will look like. So next we'll be talking about the laboratory test in measuring the dengue's antigens, dengue serologies. So one of the most common technique they use in the laboratory will be the ELISA methods. Just for your knowledge, besides ELISA method, there are actually other techniques they can use to detect NS1 antigen, IgM, and IgG, depends on the laboratory and the setting. So apparently, ELISA methods will offer a higher sensitivity and specificity as compared to your rapid diagnostic test kit. But the downside is that these samples will be run in the lab, so it lacks of convenience because you need to syringe out the blood and send to the lab, and the lab technicians will do the test for you. As opposed to this rapid combo test, the result will be available within 15 minutes on the spot. Last but not least, we are going to take a look at the dengue PCR serotype. I believe that as you read the guidelines or even articles, definitely you'll come across this. So this is actually a molecular test specifically to detect the dengue virus RNA. So it's a very specific test, in terms of diagnostic. But the downside of this is that it has a high turnover time and is costly, as opposed to the test that I mentioned to you earlier. So such tests would commonly be used only for research, surveillance, and genotyping purposes. In terms of diagnostic during acute management, I think we will still be using the first two tests that we mentioned. But before I end this and move on to the next slide, right, I must drive home one very important point. Dengue infections ultimately, is a clinical diagnosis from the beginnings. But when you have done the dengue diagnostic test, for example, if the dengue combo test or the dengue serology test are negative, we cannot say with confidence that the dengue infection is negative, especially when the clinical symptoms are strongly compatible with dengue infections, especially the blood parameter trends. So in that case, most of the time we will repeat the test again after certain time intervals to look for the seroconversion, because ultimately the positivity of this test also depends on the time or the day of illnesses when you are measuring it. And ultimately, if there is always a clinical doubt or there is a dilemma, we will always seek our infectious disease specialist opinion, or even dengue specialists who are experienced in the management of dengue infections. Now we are going to take a look at each of the components that will be reported in the dengue diagnostic test. Broadly speaking, they can be divided into two components. So number one would be the NS1 antigens, which is the NS1's protein that will be secreted during the viremic phase. So number two would be the dengue serology or dengue antibody test. So both the antigens and the antibodies, they are not synonymous, and they will be secreted at different phases of the dengue illness. Hence, it's important for us to have some background knowledge on each of these components so that we can interpret the dengue test correctly. Firstly, we'll be looking at the dengue NS1 antigens. As I have alluded earlier, this NS1 antigen will be secreted during the viremic phase. Hence, it's logical to say that this antigen will be detected during the early phase of the dengue infections, which correspond to the dengue febrile phase. So normally this NS1 antigen could be detected as early as day 1, or sometimes it can be detected later, but in general they should be detectable within the first 5 or 6 days of illnesses. And these NS1 antigens will start to drop from day 4 and day 5 of illness onwards, and usually they will become undetectable during the convalescent phase. So keeping this in mind, so during the viremic phase, especially when you are taking this test during the day 2 onwards until like day 6, we normally would expect the NS1 antigen to be positive. So next, we'll be looking at the IgM antibody. So this IgM antibody will develop later as illustrated on these diagrams. So here the NS1 antigen will disappear, then followed by the formations of the IgM and IgG antibodies. So IgM antibody will develop earlier than IgG antibodies, and they are normally detectable after 5 days of illness, which correspond to the taperings of the NS1 antigens, and they may persist up to 60 days of illnesses, and then only they will disappear. And it's because of this reason, if the patient is asymptomatic, there is no reason for you to do a dengue test, because if your IgM turn out positive, it has no clinical significance. You need to tell that most likely in the last 60 days, he could have dengue infections. We could be a subclinical infection that the patients may not, have any active symptoms during the time. So it's only useful for symptomatic acute dengue infections. So the last components we'll be looking at will be the IgG antibody. So this will be the last antibody. They will be secreted during the dengue illnesses. So normally it will be positive after day 7 illness. So once positive, the IgG antibodies will be there lifelong. So hence, if patients who come in with acute infections within the first week illness, you do the dengue test, the IgG is already positive. Most likely that's reflecting the past infections. Hence, we call this secondary dengue infections, which means that patients have a history of past dengue infections, as opposed to primary dengue infections where they shouldn't have IgG antibody during the acute febrile illnesses. And also, if there is a diagnostic dilemma, sometimes we can also repeat the dengue serology test. And normally, the optimal time intervals will be between 10 to 14 days between the PET zero. But again, like what I say, a negative dengue diagnostics test cannot conclusively rule out dengue, because some cohort of patients, they may just seroconvert later. But nonetheless, the dengue infection has to be actively managed even from the outset. Before we discuss about the importance of dengue notifications, I would like to share with you the epidemiological triad, which is a triad that we will be looking at whenever we are studying infectious diseases. So in this epidemiological triads, we'll be looking at 3 components. So number 1 will be host. So in the case of dengue, the host will be human beings. And the agent will be represented by the dengue virus, would be carried by the vector known as Aedes aegypti, the Aedes albopictus mosquitoes. And also we'll be looking at the environments. In this case, I will be talking about the breeding sites of the environment, which will be influenced by the climatic changes. So why is notification important? Because notifications will allow the public health systems, to estimate the burden of disease, and also, most importantly, to search and destroy the Aedes dengue breeding sites. In that case, we can actually break this part of the cycle and also break this part of the cycle, so that we can bring down, the burden of the dengue fever. Dengue notification is actually mandated by the Infectious Disease Act. Just like where most parts of the world are practicing, there is a law that governs the notifications of clinically as well as a publicly important infectious disease. So for dengue infections, the current law mandates that the notifications has to be done within the first 24 hours. This is very crucial because, as we know, dengue infection is actually a public health threat, and it has the propensity to turn into an outbreak if the disease is not controlled. So therefore, by having a timely dengue notification, it will allow the public health team to be updated on the disease burden. Not only that, it will allow them to be, able to look for and destroy the dengue breeding sites from time to time. As I mentioned in the epidemiological triad, this will allow, interrupting the cycles by breaking down the environment that contributes to the dengue breeding sites, as well by destroying the agents, which is the Aedes viruses. Finally, we have come to the last part of the discussions, in which we're going to talk about dengue management. In this lecture, I'm not going to discuss in depth on the dengue management, but I believe that you can always look up for such informations from the dengue CPG, or the dengue clinical practice guidelines. So broadly speaking, just like the management of any other diseases, the first part of the management is always performing a comprehensive history takings, aiming to establish the clinical profile of the patients. And next, you perform a thorough physical examinations. Following that, you will order some laboratory tests. Ultimately, based on this comprehensive assessment, you'll be able to outline your care for the patients, which will determine whether the patients can be monitored as outpatients or to be managed as inpatients. And for those who are receiving inpatient cares, we need to know about the choices of fluid. So broadly speaking, it will be crystalloid or colloids. And also in patients who are severely ill, who have hemorrhagic complications, then we will need to consider the usage of blood products. And also in patients who are severely ill, they will be admitted to ICU to receive intensive care, where the organs that have decompensated will be provided support. So then in practice, I think I just want to talk about how can we formulate a complete dengue diagnosis. So in practice, normally the dengue diagnosis will be written in this manner. We will mention, like, first of all, we'll say dengue fever, day 1 of illness. And then in patient defervescence phase, we will even mention how many hours post defervescence, and then is there presence or absence of warning signs, and also whether is patient in shock or not in shock, and is there any other concomitant complications. So by highlighting each of these components, it will allow us to strategize our management for inpatient care. So again, I think repeatedly, regardless you are learning from this lecture or you're attending workshops, these two diagrams will be mentioned repeatedly, because it carries very crucial informations. As we know, different clinical phases will pose different clinical challenges, and you need to pay attention to it when you're caring for the patients that is in the hospitals. In the final part of the lecture, I would just like to run through some of the important components that are present in the dengue chart. So dengue infections, there's no specific treatments, and the management are largely supportive. And because of these reasons, fluid prescriptions forms the cornerstones of the dengue management. And for fluid prescription in dengue infections, we are actually prescribing based on the body weight. For instance, the maintenance rate will be calculated using this formula, 1.5 cc per kg per hour. And for the graded boluses, which depends on the patient's hydration status, it can range between 5 cc per kg per hour up to 20 cc per kg per hour. Coming back, so because it is a weight-based fluid prescription, it's important for us to take down the patient body weight. And for individuals who are obese, with a BMI more than 27.5 kilogram per meter square, we will actually calculate the adjusted body weight, and use it during the fluid prescriptions. So basically, the dengue chart is just a summary or graphical visualizations of the trend of the vital signs. As you know, dengue infection is dynamic. It will shift between phases to phases, and therefore having a dengue chart will allow us to keep track on the dengue phases. So there are actually quite a number of components in dengue chart, but in the interest of time, I will just highlight some of the components that I think that's worth highlighting, especially for the practicing doctor. First of all, will be none other than the temperature, which is one of the vital signs. One of the pitfalls is that sometimes you may not appreciate that the fever may not be due to the dengue infections itself. For instance, if the patient having persistent temperature spikes, we should always look out for other common cause of fever in the in-hospital setting. For example, we need to watch out. Could the patient have developed a superimposed infections that was acquired nosocomially, or could the patients have thrombophlebitis from the Perils that the patient is having? So, and also all the fever will need to be actively controlled. Like what I mentioned earlier, if a persistent high-grade fever, sometimes it may cause neurological impairments. So we will always do active therapy sponging in patients with throwing, high-grade fevers. And also in the very rare instances, in patients who are critically ill with, critically low platelet, severe transaminitis, sometimes the persistent fever could be the signs of an ongoing HLH, also known as hemophagocytic lymphohistiocytosis. So besides that, we will also be on high alert, especially we are seeing dengue patients with unexplained tachycardia or with resting tachycardia, because tachycardia could be an early signs of compensated shocks, or sometimes it can be just a late signs of decompensated shocks. So all the tachycardia should be looked into and the cause to be identified. Again, I would say that tachycardia is not a diagnosis itself. It arises because there is an ongoing pathologies. Hence, differentiating the cause of the tachycardia is very important, because sometimes not all tachycardia is because of dengue infections directly, because in some cohort of patients, for example, the tachycardia can be due to other components. For instance, the tachycardia could be due to undiagnosed hypothyroidism, in the sense we will actually need to manage the hypothyroidism instead of manage it as per dengue protocol. Also, very importantly, other differential causes for tachycardia, such as fluid overload can, or heart failure itself can also cause tachycardia due to the sympathetic response or respiratory distress. Hence, I would say that we shouldn't treat the symptoms or treat the signs alone. We should always combine it with other evidence in order to formulate the right diagnosis, so that you can treat the underlying pathology, which will ultimately reverse the tachycardia. So another important components will be the pulse pressure trend, because this is an empty dengue chart. In practice, you will see that our nursing team will actually chart down the pulse pressure trend. If you realize that the pulse pressure is narrowing, please be on high alert, because this can be a precursor of an impending shocks. And in dengue, most of the time they develop cold shocks, in which their CCTRV will be compromised. And the formula to calculate the pulse pressure will be your systolic blood pressures minus your diastolic blood pressures. Also, we need to watch out for tachypnea. In dengue, most of the time the patients will not report shortness of breath until the very late stage. So in the case, we will say that most of the time they may have silent tachypnea, in which the patient did not sense the respiratory distress during the early phase of the disease. This is because most of the time the respiratory distress happen because of third space fluid loss into the pleural space, and this third space fluid loss is insidious and progressive. Yeah, the patient will only be symptomatic when a significant compromise in the respiratory functions has occurred. Hence, it's always very important for us to observe the patient breathing patterns and efforts during the course of clinical management, and the respiratory rates has to be documented. The final thing that I would like to talk about is the CCTRV, in which you will definitely hear about this repeatedly. So what does this abbreviation stand for? So the first C stands for color. So we always check the patients, how is the patient's color. In other words, are they pale, the skin colors, when you look at the palm, the peripherals, you'll see what are the colors, are they pale or mottled skin. But again, I would say that to have a pale or mottled skin, these are very, very late signs. Yeah, So most of the times, they wouldn't have this unless they came in very late, or sometimes the early signs was missed out until the very late stage. The second component will be the CRT, also stand for the capillary refilling time. So a lot of time they would have per perfusions where they're in shock. So understandably, the CRT will be prolonged, which is defined as more than 2 seconds. And also temperature, we always touch the patient's hands when we are doing the dengue review because we want to feel the perfusions. Again, like what I said, dengue patients, they will develop cold shock as opposed to sepsis. Sepsis, they will develop warm shock. So they will have a per perfusion, CRT prolongs, the color appear pale. Yeah. And also the second last component will be pulse volume. In dengue, most of the time, if they are very into shock, they will have weak and thready pulse, as opposed to sepsis. Sepsis, they will have bounding pulse. And also the pulse rate, very important. Need to take note of pulse rate. And all these need to be interpreted collectively, in combinations with the patient's overall well-being, the symptoms, as well as the blood results to assist you to formulate your management plan. Overall, dengue is a dynamic disease and is progressive. It will pass through the 3 distinctive clinical phases, and early detections of those patients who are at risk of rapidly progressive deterioration is very crucial because you can intervene on time, and definitely it will reduce the morbidity or even the mortality rate in such cases. And ultimately, just like the management of any medical patients or any discipline, you require a comprehensive clinical assessment and you need to apply interpretative skills to the signs, symptoms, and results to formulate your clinical plan. And dengue chart, like I mentioned to you, it provides a very good snapshot overview, on which phase is patient in and what are the red flags that you can detect during the course illness so that you can manage it accordingly. And in most part, I think this lecture is just the beginning, I would say, because ultimately you need to familiarize with dengue management, and most importantly, of course, to have clinical experience. I believe that eventually all of you will rotate through your dengue posting. From there, you'll learn from your patients, to apply whatever lessons you learn from this lecture or from the dengue CPG and apply it, and also learn it from your senior. Thank you so much for your attentions. And before I end the video, here are some important take-home messages. So dengue is endemic in subtropical and tropical countries, just like in Malaysia. And dengue infection is a dynamic disease, and timely interventions could prevent untoward complications or even mitigate or reverse the disease severity. They will lead to improved clinical outcome. And I think all of us, including myself, we always update ourselves with the latest dengue CPG's guidelines as well as managements. Thank you for your time and look forward to see you again in the next lectures.